So it's time to start. Can you please sit down? And if you have sat down, actually I was not joking, we introduced this new prize for the most active student, and we found out the way. So at the end of the meeting, you will vote among yourselves who was the most active student, okay? And we didn't find out the prize, but it will be a surprise. So, okay?
But there will be a prize.
But it will be a very nice prize, so please be a little more active and use this opportunity to ask the faculty, okay? Thank you.
Wonderful. So this, for sure, is going to be a very dynamic session then. And it's a pleasure for me to first introduce Professor Cate from the Netherlands that will give us an overview of the atherothrombotic process. And then we'll move towards to Professor Raffaele Caterina from Pisa University that will talk about all the antithrombotic strategies available nowadays to compensate for the atherothrombotic event. So, please.
Thank you very much for the introduction and the invitation to be here. I just discussed with Professor de Caterina that the prize will be in ice cream, but a special one perhaps, so you'll see tonight or whenever the prize is awarded. It's great to be here in this pleasant environment and to discuss with you this topic, atherothrombosis. And these are some disclosures that are not very relevant for this presentation, but I want to show them, to share them with you. And these are the points I'd like to address in this presentation. If time allows, I hope so. I will go through it. And if I'm going too fast or if you can't follow it otherwise, you can wave your hands or scream or ask questions, because that's awarded. So that's always an option. I want to discuss with you atherothrombosis as a global problem, the underlying disease, atherosclerosis. Now, I should tell you, I'm from the Department of Internal Medicine and Vascular Medicine. I'm not a pathologist. I'm not a researcher in atherosclerosis so much. Some of you may be much more familiar with all the inflammatory processes that are ongoing. My topic is more on thrombosis and coagulation and the interactions with the vessel wall in how it drives atherothrombotic disease. So also feel free to correct me if I'm saying stupid things. I want to touch on an event that's also in the atherosclerosis world very important. I think the difference in the shifts in time from ruptured plaques towards more eroded surfaces on which thrombi form. And then I want to discuss the importance of coagulation processes, or proteases, for atherogenesis and thrombus formation. And then finally I'll bridge to Professor de Caterina to discuss the antithrombotic medication. It's a global problem because atherosclerosis is a globally occurring vascular disease. It occurs in everybody, it's age dependent, and it develops under the influence of inflammatory pressures. Already at an early age, the detectable lesions are present, such as what we used to call the fatty streak, and maybe that phenotype is also changing a bit with time. But there is inflammation going on, perturbation of endothelial cell activation, and the formation of an atherosclerotic plaque in the course of our lifetime. And eventually we will all reach an age that we are at high risk or relatively high risk to develop the complications, which are, we know them very well, myocardial infarction, ischemic stroke, or peripheral ischemia due to thromboembolism in the peripheral circulation. And all these consequences or complications are the result of thrombotic occlusion of blood vessels. And it's a globally important disease. It's also increasing with time because of the aging, the better life expectancy in the population, and it's a disease unfortunately occurring equally in, see if this works, in women and in men. So that's a pity, but that's how it is, and you can see here there is an increasing trend in the occurrence of ischemic heart disease and cerebrovascular diseases, the majority of which is related to thrombosis. And that's also one of the reasons to celebrate World Thrombosis Day on the 13th of October. So that's a day that's not only devoted to venous thromboembolism, but certainly also to these arterial consequences of disease. So now that we know that it's a globally important process, I want to discuss briefly which factors trigger this process or aggravate atherosclerosis in the course of a lifetime. This is another picture, another depiction of the complications that may occur. And this figure is from a paper in 2008, but it's still relevant. And the only element that is missing here may be hypercoagulability, increased activity of the coagulation system as a driver of atherosclerosis, but most of the other elements are still there. And you may not be able to read it, but in white, the boxes in white are the factors, the risk factors that we cannot change, such as age and gender. At least most of the time we cannot change that. Family history of disease, so inherited factors in general is also something that we are born with. In purple are lifestyle associated factors like diet, body weight, physical activity. And these factors, of course, can be modified if we really do our best. And in yellow are another class of modifiable risk factors that relate to blood pressure, hyperglycemia, lipids, etc. And of course, these factors also can be modified in part by diet and physical exercise, but also with additional medication if we want to. And there's clotting activity, and I'll come back to discuss that. I just want to highlight one particular factor that is not so much in most of these schemes, and we tend to forget about it. But there has been a lot of recent attention to the contribution of air pollution, because it's a huge problem and it's present everywhere. And it's estimated in this very recent, very thorough analysis that it reduces our life expectancy with approximately 2.2 years. So it's definitely very relevant. And even if we are in Nice, you may say, sunshine and what's wrong with this climate, but if you look carefully, it's not totally free from pollution. It's here somewhere. But where I come from, the Netherlands, is terrible. And I live in Maastricht, which is down south, and it's beautiful, but at the same time it's a highly polluted area. So we're better off in Scandinavia, or maybe the Pyrenees, or some other places, Scotland, if we want to improve our life expectancy in that direction. But I'm not supposed to talk about air pollution, but I just want to touch on this because it's a very important element that it's oftentimes ignored by policymakers. So what are the key players in atherothrombotic disease from a coagulation perspective? First of all, it's important to recognize the different forms, the different types of atherothrombotic disease. It can be acute, and I highlighted this in red because I want to embark a little bit more on this, on the acute manifestations. But the first note should be that, of course, it's better to aim for prevention. So if we can prevent atherothrombosis, that would be better. We can modify the risk factors, that's one approach. And theoretically, by giving platelet inhibitors or coagulation inhibitors, one might also be able to reduce the risk of the first atherothrombotic event. And that, for instance, is an opportunity in subjects with a high risk of atherothrombotic disease, such as patients with peripheral vascular disease, high risk of myocardial infarction and stroke. And there is a strong indication for aspirin, for instance, one of the platelet inhibitors. I leave the rest of this discussion to Professor De Catarina, just to indicate that there are different phases in our life when we can do something in order to prevent or handle the dangers related to atherothrombotic disease. But I want to highlight on the acute events, because unfortunately many of us are not able to postpone the first event forever. So at some point we may suffer from chest pain, and that may be a first indication of an acute myocardial infarction. And if we're lucky and we can reach a hospital and call an ambulance, they may be able to get in time to see us and to do some diagnostics, an EKG that may be suggestive of myocardial infarction or ischemia at least, do some additional biomarker testing to classify whether the chest pain is non-cardiac or cardiac. And I'm not a cardiologist, so I'm not going to the differential diagnostics, but just this to illustrate the acute event and what we do with it. How do we handle the acute atherothrombotic event? If we're lucky and we have the facilities in the area, and this is typical for the United States, to put on the website all the turnaround times. So how many minutes does it take before you end up in the cath lab where they can do percutaneous coronary intervention and look by the angiogram if there is an obstruction or not, and if there is, how to solve this. So the interventional cardiologist, or for ischemic stroke, the interventional radiologist, will try to reopen the occluded vessel. This comes down to getting into this narrow lumen. There have been studies done to see if it would be of advantage to remove the clot from the coronary circulation. These studies were essentially not good enough to continue on this level. So currently PCI and stenting is the mainstay of the management of coronary thrombosis. It's different with ischemic stroke because there is a definite place nowadays for clot removal, as indicated in the next slide. This is from the carotid artery. And if you're lucky enough, you make it to the hospital in time, and there is a fairly narrow time window, and you're able to remove the clot from the carotid artery with this stent retriever. So this is the clot indicated here. Then your chances of recovery from ischemic stroke will also be improved. This is oftentimes associated with prior thrombolytic therapy in order to dissolve at least part of the clot. And subsequently, we give antithrombotic medication to reduce the risk of recurrence. And also in the peripheral circulation, if there is ischemia due to thromboembolism in the peripheral circulation, we can do PCIs, stenting, vascular surgeon, interventional radiologist, or they can bypass if it's too severe pathology. So there are different strategies to circumvent problems of acute thrombosis. Now this was the thrombus that formed, that precipitated coronary ischemia or ischemic stroke or peripheral ischemia. And what are the key players in this thrombus, except for the fact that there is a damaged endothelial cell layer. So there's something wrong with the vascular endothelium, otherwise the thrombus wouldn't stick to it. Sometimes there is a classical rupture of this atherosclerotic lesion to which the thrombus attaches, otherwise it's an eroded area. And we know from many studies from the past, and this is an old slide that goes back to the PhD thesis of Dr. Valentin Fuster, who is world famous for all his pioneering work in this context, and also the Badimon group, and subsequently did a lot of work in figuring out the importance of platelets as key players in atherothrombotic lesion development. So platelets were identified and subsequently studied in their behavior in driving thrombosis in the arterial circulation. And there have been many very elegant flow studies to mimic this situation ex vivo to study the process in greater detail. So we know from decades already that platelets are very important players in the process of atherogenesis and atherosclerosis. And if you look at this schematically, you could see that under physiologic conditions, platelets do not adhere to vascular endothelium, but as soon as the endothelial barrier is damaged, ruptured or eroded, and cells are activated, the platelets are attracted to the surface in order to provide hemostasis, because it's basically healing of the vascular lesion that they want to do. That's where they are trained for it to do. So platelets will stick to collagen and other compounds, proteins that are expressed in the subendothelial layer, and they will try to heal off the surface. But sometimes, and certainly in conditions of inflammation that is ongoing during atherosclerosis, this process can become aggravated. And if there are interactions with inflammatory cells, such as indicated below, and coagulation activity is amplified by the surface that is formed through this membrane phospholipids, then the process may run out of hand and may turn into a thrombotic lesion. although it's from autopsy studies, it seems that this is oftentimes also a non-symptomatic process, so a thrombus may form even without presenting somebody with symptoms of ischemia. So it can be asymptomatic or symptomatic, depending on the degree of occlusion that is achieved and the localization in the coronary or cerebral circulation. Now, platelets are very important elements of the arterial thrombus that is formed, but also fibrin formation is indicated in red, and the co-localization of these processes have been recognized for many years. So, in addition to platelets, coagulation factors play an important role, and this is one of the terrible examples of coagulation cascades that you should immediately forget. But I have to pinpoint to, well, some of the important regulators at least. I put a heart around thrombin because it's one of the regulating proteases. It regulates both anticoagulant and procoagulant pathways depending on the physiology or pathophysiology that is ongoing. And under physiologic conditions, thrombin is the most important agonist of protein C activation. And activated protein C is a very important anticoagulant, but also an anti-inflammatory protease that protects the endothelial cell barrier against inflammation and disruption. And it provides an anticoagulant milieu, which is very important. So under normal conditions, as we sit here, we hope that we generate sufficient thrombin in order to maintain the physiologic, the homeostatic situation. But if there is sufficient expression of procoagulant proteins like tissue factor, which can be exposed in the eroded or ruptured plaque, that may drive a procoagulant pathway that generates more thrombin and fibrin subsequently to accelerate the process of thrombus formation. And this may overwhelm locally the anticoagulant features that the blood should have ideally. And this is depicted in this cartoon, and it's also a bridge to the next speaker, because if you wonder about the key players, what are the key players? Platelets, well, endothelial cells, there's not so much we can do about it at the moment, but the key player, platelets, we can do something about, and also the coagulation proteases. We could do something about it with medication, so with platelet inhibitors or anticoagulants. And again, this will come back in the next presentation. Now, I mentioned a couple of times erosion and rupture. So what's the difference, or what does it matter? And this is another long series, decades of studies that were done to address, from autopsy studies and experimental work, the process of atherogenesis and plaque stability and instability, and the concept of vulnerable plaque that formed the basis for the research in understanding atherothrombotic lesions. And this is again a summary of some of these differences that were observed by the pathologist. If they looked at the lesions, they characterized basically two different types. Those with plaque erosion, where the thrombus was basically sitting on top of what seemed to be an endothelial cell layer, but it was usually not intact. So it's an interrupted endothelial cell layer with a thrombus sitting on top of it, which is different from the lesion that was observed in the ruptured plaque, with the thrombus seems to infiltrate into the vessel wall. And of course, in the case of erosion, but also rupture, the thrombus can be non-occlusive, as indicated here. There is still a lumen left, or it can fully occlude, in this case, the coronary artery. So these are different manifestations. And it's been unknown for many years what the differences are between these processes. And I still think we do not understand fully what the difference is between these lesions. But there are some indications that these are really different processes, in a way that the ruptured plaque is due to the unstable plaque, or is driven from the unstable plaque that is characterized by a lot of inflammation, by a lack of stabilization due to limited involvement of smooth muscle cells and collagen. So this is clearly a very unstable milieu that can easily rupture and fragment, also due to intraplaque hemorrhage, etc. So one can understand this concept of unstable plaque and plaque rupture. The more stable plaques that are seen on the right side in cartoon have different characteristics. They are less vulnerable to rupture, but still they may be thromboinflammatory more at a surface level. And is this important? Yes, it is important, because there is also a time trend that we come from an era in which there were relatively many unstable plaques and ruptured plaques underlying myocardial infarction, to an era now where we see much less ruptured, but still a comparable number of eroded thrombi, eroded plaques. So apparently some things are changing in time. And the people that have addressed this, that studied it in detail, here Pasterkamp in Utrecht is one of the people that works on this, and Peter Libby in particular in Boston. And they have spent decades of research in looking carefully at these plaques and studying these mechanisms. And and in their observations, this can perhaps be linked to the changes in the management of the patients that we see, and the fact that during the past decades, with the introduction of antihypertensive medication, lipid-lowering medication, attempts to reduce smoking burden, maybe changes in air pollution, who knows, this leads to different types of atherosclerotic lesions, but still, and also in a shift in the clinical presentations. At the same time, there is still a substantial proportion of myocardial infarctions and other atherothrombotic complications that occur, so it has not eliminated the disease, unfortunately, but it has changed the presentation and maybe postponed further the acute events in the course of our lifetime. So we hope with all the managing these cardiovascular risk factors that we postpone this basically to the last day that we live, and if we then on the last day die at the age of 95 or something due to myocardial infarction, then so be it. But that would be a change as compared to the situation in the 60s when we could die at the age of 50 or 60 due to the same diseases. So the last slide on this is from the most recent paper from Peter Libby and Geert Pasterkamp, again, schematically summarizing these the ruptured plaque versus the eroded plaque. Now they propose, and that's why it is important for the understanding of the involvement of platelets and fibrin clotting factors, they proposed that these are also mechanistically different processes, that in the good old days, so to say, the ruptured plaque was driven by tissue factor within the plaque and by collagen and other platelet activating substances, and that now we would see more often a situation where other players are involved, including neutrophils and neutrophil extracellular traps. It's a bit fashionable, but they may also play a role in the eroded plaque-driven thrombus formation. And this may link more to other coagulation factors like factor 12, factor 11, and platelet interactions that may play a role. But if we really are seeing a shift from a more fibrin type of clot towards a more platelet-dependent clot is something that I doubt. And there's no indication from the clinical management, I think, that antithrombotic medication is also shifting in time or should shift in time to focus more on these other mechanisms. But we have to see, of course, reducing or inhibiting inflammation has been shown now to be an important aspect in atherosclerosis, also in the clinical studies. So it may be that we come to better tailored therapy eventually. Finally, what about coagulation proteases and hypercoagulability? Well, to start simply, or relatively simple, hypercoagulability is enhanced or increased clotting activity in blood, because usually this depends on blood samples. We collect the blood sample, we observe that there is an elevated fibrinogen, for instance, or there is a thrombophilic trait, a factor V Leiden mutation, that puts it at risk for venous thrombosis, but also to some extent for arterial thrombosis, or there is an increased clotting activity, a D-dimer fragment, and all of these in large population-based and patient-based studies have been shown to increase the risk of coronary heart disease. So apparently, even the factors that we consider typical for venous thrombosis risk also provide a certain risk for arterial thrombosis. And of course, the magnitude of these risks is sometimes not very impressive, but still it makes us thinking about the biological relevance of hypercoagulability as a risk mechanism. And how is it a mechanism? This is another example from a study that we did in the past, linking thrombin antithrombin complexes in blood, so that's a marker for thrombin activity, to coronary calcification in coronary CT scan studies from patients with coronary disease that had little or no or severe calcification, and we also observed that there was an association between the level of thrombin activity in blood and the degree of coronary calcification as a marker of severity of atherosclerosis. And you could do the same thing for D-dimer, for instance, and you also observe, and we don't have to go through the details, an increased risk of peripheral artery disease and even mortality in patients with systemic atherosclerosis. So that's one aspect. So if we look at the blood sample, the more thrombin you generate, the more fibrin you form, the more active the clotting system is, the greater the risk of coronary heart disease and other manifestations of atherosclerosis. Now, there are two important issues here if it comes down to clotting. One is, this is the blood compartment. We've discussed this. This is the conventional or the old-fashioned way of looking at plaque rupture, exposure of tissue factor collagen, triggering a thrombus, and the thrombus is sitting very in close contact with the vessel wall, with the intima. And the interaction between these processes is probably also an important driver of vascular remodeling subsequently to thrombus formation. So it's not so much just a clot and embolization of the clot, lysis of the clot, we hope that that takes place, but it's also the close interaction between these compartments that can be a further driver of thromboinflammation and vascular remodeling. So that's another way in which clotting can influence, can have impact on this damaged vessel wall. And if you look one more time at the pathology studies, you recognize that these interactions are quite intense and intimate. These are the ruptured plaques on the left side, and on the right side the eroded plaques. But in all cases there is a very close contact between these compartments. And you can imagine, because these are studies done in patients that suddenly died from thrombosis, so these are the sudden thrombi, but also in these subjects there was evidence of formerly or previous formed thrombosis that were already embedded and encapsulated in this remodeling process of the vessel wall. So there is a very close contact. And the third issue is that there are clotting proteins expressed within the atherosclerotic plaque. We knew already for decades that there is tissue factor and there is factor 7. It's the work from Cy Wilcox and others in the United States. But there's also factor 10, and there is also a number of other clotting proteases being present in the vessel wall, in part because they are probably generated by vascular smooth muscle cells, by fibroblasts maybe, and in part because they may have been infiltrating the atherosclerotic lesion. And if you test it, you can also discover that there is a lot of thrombin activity in these lesions, particularly in the early lesions. It's quite potent procoagulant material. And if the lesions become a bit more older or more advanced, then some of this clotting activity is lost. And finally, you also can detect the end product. Fibrin formation is present, and this is a mouse study. The previous data were from humans. But in mice, you see there is an age-dependent increase in fibrin formation in atherosclerotic vessels, in ApoE mice, ApoE-null mice in this case, as evidence of clotting activity within the vessel wall. So what does it mean? And this is an even more terrible slide for which I apologize, but I just want to highlight a few aspects here. And that is, in the first place, indeed, if you have more clotting activity, wherever it is, in the systemic circulation or in the vessel wall, if you have a genetically driven hypercoagulability, you aggravate atherosclerosis, as indicated here. So you get more aggressive, more pronounced atherosclerosis of a more unstable plaque phenotype, in this case, in this particular study. If you have less clotting activity, hypocoagulability, you have less atherosclerotic burden. So apparently the level of clotting activity regulates, has impact on the progression of atherosclerotic disease in mice. So far, the evidence in humans is less robust, at least. And this is studies from Julian Borisov, seen in the right upper panel, who was a PhD student at the time. To make it a bit more simple, because how would it work? If you have more clotting activity, why would this impact atherosclerosis? How does it work? The idea is, but we're still collecting evidence, I think, the global scientific community, to see whether indeed these interactions between clotting proteases and protease-activated receptors are pivotal in driving these processes. And that's probably what it is. And I just want to focus on two of these PARs and not get too much into the details of their activation. These are very intriguing receptors. They are sitting on transmembrane receptors. They're sitting on, are present on many different cells, endothelial cells, smooth muscle cells, platelets. Virtually all cells have PAR receptors, different types, different classes, and different ligands. And we only know something about, well, some of the coagulation proteases and how they interact, but there are also other metalloproteases, trypsin, elastase, that may also activate these PARs. So the spectrum of ligands is quite substantial, probably. Now, to come back, just to give an example, activated protein C was driven by thrombin to protect us, if you remember. Physiologically, we have anticoagulant protein C being generated, activated protein C that activates PAR-1. PAR-1, where is it? PAR-1, here. Activates, and it provides cytoprotective effects in the cells. So it protects the endothelial cell barrier and it maintains homeostasis. But the same receptor can also be activated by thrombin, and that's quite intriguing. And one of the people that has really spent work on figuring out how this works is John Griffin in Scripps, Professor Griffin, a very important scientist in our field, who figured out that it's only a few amino acids difference where these proteases act on the PAR receptor to cleave and activate the PAR receptor. So here is APC is normally active, but in 5 amino acids further up, thrombin activates the same receptor with a totally different result. So the result of APC generation has protective effects, as indicated here. Thrombin activation results in offensive effects. And I think we're still in need of much better understanding how this process is regulated. What determines whether one or the other protease act? Is that a matter of concentration or receptor density or conformation? It's probably a result of many of these processes, or receptor-receptor interactions. There are many things that can determine this process. I'm almost done with this part of the story. And with this presentation, actually. The second receptor, but it's so fascinating that I have to share this with you, even if it's a bit complicated at times. The other receptor, PAR-2, has been shown to be involved in atherogenesis. So if you knock out PAR-2 and you cross these mice with ApoE null mice, you see that there is less atherosclerosis. It's not so impressive, but there is statistically significant effect in this Japanese study. It was also observed, this protective effect, in a study from Phil Omens from the United States. So 2 studies make up a good story. And it's also shown in the circulation paper that this is probably mediated through NF-kappa-B mediated or driven regulation of pro-inflammatory cytokines that are less abundant expressed in the PAR-2 null mice. It's tempting to speculate that factor 10A would be an agonist of the PAR-2 receptor and that this may link, in fact, the clotting protease 10A to atherosclerosis, but the evidence is still not there. So how do we get the evidence? Because what I have shown you is all associated evidence, circumstantial evidence. You link something in blood to an outcome in the vessel. And even the mouse studies, they show a certain association, but we still don't know the exact key players. But we do know, because there are several studies now, including this one from our own group, that have shown that if you give the thrombin inhibitor dabigatran to these mice with ApoE null phenotype or genotype, that you can actually dramatically prevent the occurrence of atherosclerosis, as indicated here. This is a very specific model for advanced atherosclerosis due to intima proliferation introduced by placing this cuff around the carotid artery. So thrombin inhibition gives a sufficient or quite robust protection. The same can be achieved with activated protein C, the other agonist that activates PAR-1, and probably by this mechanism also protects the mice from developing atherosclerosis. And the final evidence that 10A is also involved, although this may in part still be explained by downstream thrombin generation, is that if you give the rivaroxaban, the 10A inhibitor, that is also used in our patients, that you can actually diminish the atherosclerosis burden in the same ApoE mice, but also if they have already established atherosclerosis and you continue on rivaroxaban treatment, you can reduce the burden of vascular disease. So finally, can we translate any of this to the clinical work? Not yet, but we are there. We reach a moment in time and in research that we begin to understand some of these mechanisms, some of these interactions. And it's tempting to at least assume that some of the anticoagulant effects that we achieve by treating patients with direct oral anticoagulants, like dabigatran or rivaroxaban, their protective effects may be mediated in part through interfering in the interaction with 10A or thrombin with these protease-activated receptors, and that may be actually one of the elements of vascular protection that we like to see in our patients. Maybe that's the case, we still don't know, so maybe the beneficial effect of anticoagulants is mostly focused at prevention of thrombosis, and the same with antiplatelet therapy, but I leave that for the next presenter. So as a final example of why we think it's tempting at least to assume that there is a sort of vascular protective effect comes from this rather recent study in which the combination of rivaroxaban with aspirin was tested against either agent alone and shown to provide substantial protection. In the subjects that received the combination therapy, the dual pathway inhibition. This reduced the cumulative risk of cardiovascular mortality, stroke, and myocardial infarction. And it might be that it also improved to some extent. That must be the ice cream. Poor excuse. Sorry. Thank you. This is nice. And it may be, and this is the last slide, fortunately, for me at least, and for you too, but maybe, because the question was, is this all due to prevention of thrombosis? That would be the simple answer. Or is there something more going on? Now, there are a few studies that suggest that also in patients there is a certain degree of vascular protection, if you like. It's a company word in a way, so I don't like to use it too often. A certain protective effect of the use of direct oral anticoagulants in patients with vascular disease. And this is just one example of a rather elegant study, but it's not a randomized trial, so you can argue all kinds of things against it, showing that in the subjects in dark blue, they received a direct oral anticoagulant. The others did not in light blue. And then there were patients with vitamin K antagonist. And I don't want to discuss those because that's a very difficult story. But it seems at least that some of the features of plaque instability, like this one, low attenuation plaque, is a marker for plaque instability on CT scanning, that is favorably influenced under the effect of the direct oral anticoagulant. So this, again, is an association, but it may provide some support for the idea that it matters, the coagulation proteases and their effect on the vessel wall. This is a miracle drug, Sam. Thank you. Now, concluding remarks come back to the agenda, basically, so I don't want to sum up this whole thing again. I think I tried to discuss with you the global problem of atherosclerosis, the differences in mechanisms, in the way that thrombus is triggered, whether it's erosion or plaque rupture, and the potential role that coagulation proteases may have in this whole process. Not diminishing the important role of platelets, because that is they remain key players. I haven't even touched on fibrinolysis, which is another important mechanism in vascular remodeling, etc. So I think for the future we can be quite hopeful that some of these effects may turn out to be true and relevant, and that if we treat the millions of patients that we do treat now with direct oral anticoagulants, we can eventually perhaps achieve a bit more than just preventing thrombosis. And with that, I'd like to thank the people in the laboratory, the staff members, the many PhD students that are so important in all the work that we do, and the laboratory technicians that we should not forget. It's an important, very important group of people. And I thank you for your attention.
So, thank you so much for this excellent overview of the atherothrombotic process, very complete and very comprehensive. And now the audience that has been paying attention and wants to win the prize, so they have plenty of questions, if not. So remember to introduce yourself.
Hi, I'm Lianne from the Netherlands. Thank you for your interesting talk. You touched upon the differences between plaque rupture and plaque erosion. And I'm curious what your theory is or what your thoughts are on plaque erosion. So what do you think is the underlying pathologic mechanism in plaque erosion?
In plaque erosion?
Yes.
Yeah, well, I don't want to go back to these slides again, but there was one illustration in the Peter Libby Posterkamp paper, and maybe you're working with them, I don't know, but
yes.
where you see these endothelial cells that are more or less come off the surface, they are detached. So it seems that insufficient endothelial barrier function was one of the initiating events. And I think as soon as an endothelial cell becomes detached, it will expose proteins and other materials that trigger platelets to become active and to try to fill in the gaps. And in a way it's comparable perhaps to stent thrombosis, which stents that are inserted, especially drug-eluting stents, sometimes endothelialization is also insufficient and you get these tiny little gaps which trigger hemostasis and thrombosis. And I think that is a comparable scenario to start up the thrombus process. Now in the Libby and other papers, one wants to refer to new mediators of this thrombus formation, including neutrophils that would be particularly important in eroded plaques, but I'm not sure. I don't think this is really a black and white scenario, and it's also not a case of different types of thrombus that you form. And also if you look at the comparative autopsy studies, the thrombi, they look quite similar, and platelet inhibitors work quite well, so I don't think it's yes neutrophils versus no neutrophils. It's much more gradual in its importance. And it's now that we better understand the importance of net formation, for instance, extracellular traps, to trigger some of the processes, including coagulation, that we think that, yeah, this may be an important contributing mechanism. But that still needs to be shown in appropriate studies.
Okay, thank you.
Hi, my name is Lotte. I'm also from the Netherlands. I have maybe a different question, but I would like to actually invite you to come over to our posters because we have...
Could you speak a little bit?
Sorry, yeah. I would like to invite you to our poster because we have a very nice data set on atherosclerosis and also on the endothelial cells directly from the plaques. So I would like to invite you to come talk to us about the possibilities. What do you think is the future for our experiments? If you have time.
The future...
well, just discuss your work and discuss our work in regards to plaque erosion and rupture.
Yeah, well, it's an intriguing subject, but it's very difficult for me alone to handle this from vascular medicine perspective, you think more in terms of how can you manipulate the system, and you need the pathologist and the cardiologist to understand what's going on in the molecular details. I do think, well, the problem is the appropriate models. I mean, we still rely for a great extent on the mouse models to study these processes. With all the limitations that are there, we tried also to replace animal models for more ex vivo kind of systems. So I think that may be the clue to better understand the human problems by looking more into detail in ex vivo perfusion systems or organoids as models of blood vessel disruption and activation, and to study the influences of atherogenic compounds on vascular endothelium, the human vascular endothelium. Because we do have a whole array of knockout mice and mutant mice, and that will help us to some extent to solve the issue, for instance, of the contribution of neutrophils and net release, etc. We can all molecular manipulate that, but we need to come closer also to the human conditions to better understand what's going on. And I'm happy to think it over in greater detail after the session, but you all have to help me here.
Hugo, I want to come back a bit to your statement regarding the usefulness or non-usefulness of the coagulation cascade as it is usually portrayed in old textbooks. And I want to make a provocative statement that we should still teach coagulation in part, at least, with the old schemes, because otherwise it would be impossible for students to understand coagulation tests. Yeah. This is my standpoint, and I want you to comment on this. And then I have a comment regarding these purported magic properties of the novel anticoagulants and on the atherosclerosis process. And I want to cast a bit of skepticism about this flow of thought, because we come from 50, 60 years of experience with the classical oral anticoagulants, which inhibit thrombin generation. So at the end, they do something that also factor Xa inhibitors do. And also by inhibiting the generation of thrombin, they also decrease the activation of thrombin-activated receptors. And it was never clearly demonstrated that these drugs affect atherosclerosis. They affect the consequence, the thrombotic consequences of atherosclerosis. So please comment on this.
Yeah, thank you, Rafaela. These are very important comments. Well, the first thing is the hardest part. It's about the coagulation cascade. No, but I agree, and there's no reason to reorganize this coagulation cascade over and over again, and we might as well stick to the original idea of the extrinsic and the intrinsic system, because essentially this concept is also still intact. And it's, well, yeah, for one, it's always very difficult to memorize the coagulation cascade, so therefore I never push towards, well, that you all have to understand the exact sequence of events, but it's an important concept to illustrate the coagulation cascade idea, the cascade of amplifying of enzyme formation. So from that perspective, in terms of biochemistry, it's still a very relevant concept. There are elements in it like factor 12, which we are also always struggling with. Is it important as a contributor to clotting or not? But that set aside, I think we can still accept the conventional idea. I agree. The second issue is, and I didn't want to embark on the vitamin K antagonist, although I still think that this is a very important class of agents, and personally I very much doubt whether it harms people. In fact, it may also contribute to stabilization of atherosclerosis in a way, if you believe that some of these mechanisms are important, like inhibition of Xa and thrombin formation. And that is, by all means, very well achieved with the vitamin K antagonist. The problem is that there is one important, well, whether it's important or not, there is a side effect of vitamin K antagonists, and that is that it gives more calcification in the long run after a long exposure in humans, and this is also very well studied in preclinical models, but also in humans there is good evidence that you get increased calcification. And the advocates of the DOACs, they always say, well, this is a terrible side effect of the VKAs. But I'm not convinced that that is the case. The fact that you do see more calcification is not comparable to spontaneous calcification that may be the result of inflammation. And in fact, the combined effects of vitamin K antagonists may lead to, well, a rather stable plaque phenotype. And many of our patients now enter the 90s of their life without any vascular problem. Bleeding is an important side effect, but also for DOACs. So I think there may be protective effects against, also from vitamin K antagonists, but given the background of calcification, it's very hard to demonstrate that occurs. And the DOACs do not have that side effect of calcification, so it's easier to figure out some of these molecular interactions.
And just to finalize, because you have presented your work in calcium artery score, yeah. And the thing is that, do you think that the position of calcium with all the arteries is always a harmful effect? Because definitely the burden of calcium is associated, but probably the density or distribution of the calcium may lead towards a stabilization of the vessel instead of promoting. Can you just briefly comment on this concept?
Yeah, very brief, because, well, there are others from our group, from the biochemistry, that are more experienced in this, but I think they do have good evidence that initially calcification and the microcalcification may be an important trigger of local inflammation and clotting also. But in the long run, I think it may, in fact, stabilize some of these processes as well. That's speculation, but much of this work is still speculative in nature. So,
Thank you so much. So we have to move on because it's time, and then it's a pleasure just to please applause.